So I'm in my mid 60s. How many times have my valves opened and closed in the course of my life? Any guesses? Billion, almost 2 billion. When you think of anything that has to do that 2 billion times, that's a pretty stressful. And the valves are really, really important to keeping the blood moving the right way. And over time, there are a couple of problems that occur, and you guys saw in the video. One is when they stiffen up and they get a little narrow. Remember what that was called? Stenosis. Stenosis. So the hole starts big and it pinches down. And if it goes backwards, it's called regurgitation, right? And you can imagine if either one of those occurs in one of the major valves, the forward output of blood obviously goes down, and there's some backward flow too. And all sorts of things can happen, all sorts of symptoms that these guys will talk about, congestive heart failure and otherwise. And basically, it's a structural problem, and a technical problem, and it needs a technical solution to fix, right? You can't take aspirin, you can't take a little pill. You got to fix the structure. And there are several things that can be done. One, the classic, which is really effective, open heart surgery to repair or replace the valves. And then more recently, the less invasive catheter-based approaches where you go in through the vessel and up into the heart and either repair or replace the valves. And we're going to talk about all of those today and sort of give you a sense, hopefully give you some language, some vocabulary to work with if you need to talk to your doctors, and just give you a sense of how these all work. Now, when these problems arise, as I said, there's a variety of different options for the patients. And when there are options, that's when it's really, really important to get a variety of opinions and thoughts on how best to treat and manage. And for that, what we have evolved, and Camino is a real leader in that, is a team-based approach. And it is really, really, really important to have that, to get multiple different opinions, because as I say, there are a variety of different of approaches, and it's not always obvious which is the best for which patient. And that team involves a cardiothoracic surgeon. It always involves a very strong imaging physician, because you really need to understand the physiology and the pathophysiology of the lesion. And then what's called an interventional cardiologist is the person in the cath lab who does the catheter work. So we are fortunate to have three actually very important members of the El Camino valve team here. We have Conrad Vial, who is in the center there, who actually is a pretty world-renowned cardiothoracic surgeon. So we're pretty honored, honestly, to have Conrad in our midst here. He's had a long and really remarkable career as a cardiothoracic surgeon. And also in his spare time, he's the chief clinical officer at Sutter Health. So really just a very small spare time job, right? Not a big deal at all. So thank you very much. And in some ways, one of the most important members of the team, Dr. Deepu Nair, he's the imager. And that is, if you don't know what you're working on, if you can't really understand it, you can't even start to help the patient. So very, very integral. And Dr. Nair, he is a medical director of our advanced cardiac imaging service here at El Camino, as well as Sutter Health. And then the rock star HVI individual, Kathleen Masket, she's a structural heart clinical nurse specialist. And Kathleen's going to run the show here, and she's going to try to keep these two gentlemen in line and keep this moving, and hopefully you guys will all have a good sense of what structural and valve abnormalities are and what we do about it. So Kathleen, take it over.
So I think what we're going to do is start with a case scenario, basically. It's typical to the kind of patients that we see in clinic. I'll address this to both of you gentlemen. So the story is Ms. Smith is a 65-year-old woman who has been followed closely by her cardiologist because she has an abnormal aortic valve shape. Instead of 3 leaflets, she only has 2. Her last heart echo showed a narrowing of the aortic valve and a widening of the aorta just above the valve. In addition, she has experienced new onset fatigue while walking her dog. She's been referred to the multidisciplinary valve clinic for further evaluation.
So I think the place, is this working well for everybody? Yeah, good. I think the place that we should start is that we've just heard about a patient, and every patient who presents with anything like what was just described by Kathleen really deserves an opportunity to have the problem looked at from a few different perspectives concurrently. Because our field has evolved to the point where we have a lot of different options now available to people. There used to be just one option, or really two. Don't do anything and just try and palliate symptoms with medications, or open heart surgery. And the reality is we have other lesser invasive options right now. In order to make the right choice as to which amongst those options fits the patient that you have in front of you the best, you need to bring together a team of people who will be able together to offer a more complete picture to each other and ultimately to the patient of what's going on. In this particular case, we have a woman who's having symptoms that really fit well with a valvular problem. In this particular case, it's the aortic valve, and we have evidence to indicate that there's some degree of limitation in the abilities for the valve to open. And that means that the heart is less efficient and struggles more to put blood into the system and power the circulation that we all depend on. And the first question is, how bad is that stenosis? And is it bad enough to be causing the symptoms? Second question is, if it is, what can be done about it? And along the road to identifying what can or should be done about it, you need to take a more comprehensive look at the entire cardiovascular system and be sure that there aren't some other incidental or correlated findings that require attention as well and that need to be folded into the plan for intervention. And that's where this relationship becomes really, really important.
Well said, Conrad. So I think this field of structural heart disease, it's sort of a newish term, last decade or so. Dealing with the large structures of the heart is one of the most exciting parts of cardiology, maybe one of the most rapidly expanding parts of cardiology. And there was this era where we were really focused on coronary disease and stents and bypass surgery, and that's still very important. But as the technology has progressed and as we have these new options and as the imaging has expanded, we have a whole new field of ideas and ways to treat these large structures. So to Conrad's point, I think the first step in a patient like this is often to do the usual stuff that a cardiologist will do, get a history and physical exam and check their heart with an ultrasound. I don't know, Josh, if we have the image of an aortic valve, but we can see then with ultrasound usually what's going on with the valve. And this can tell us then, is the valve narrow and to what degree? And I want to just emphasize what Conrad said. As the technology gets more complicated and there are more and more options, this field has become much more of a team sport than really ever it was before. I mean, we always had interdependent relationships, but now we really need a number of people to make a good decision for each patient. So on the left image, on your right side, you can see the valve is a bit narrowed. This is a picture of a 3-leaflet valve, but we were told this patient had 2 leaflets, called a bicuspid valve, which is a congenital, something you're born with. And this abnormality can cause the valve to fail earlier in life. In this case, the patient also, it was mentioned, had an enlarged aorta, which these things sometimes go together. We heard about the aorta being the large tube that carries blood out of the heart. And so, as Conrad said, when we look at patients, we want to get all of the information from their history and their imaging, and then we want to see, is there one good solution that could fix all of these problems at the same time so that we don't leave the patient with a residual problem. So in this case, just hearing what we've heard so far, this is probably one that I'm guessing after we did all of this testing, I would call Conrad back and say, this might be in your neck of the woods.
And the reason for that in this particular case is partially due to the fact that there's really at least two targets here that we need to try and hit for the benefit of the patient. There's the valve, and we'll come back to that in just a moment, but alongside the valve, and in fact related to the fact that this valve is abnormal in its structure, it's two leaflets or two cusps. That's the word bicuspid that you heard, rather than the more typical or the majority type 3 leaflets. We know those valves can wear out sooner, but we also know they can be correlated with abnormal enlargements of the aorta, particularly the segment of the aorta that is close, just downstream from the valve that you were seeing there on the graphic before. And although in some places in the body we are able to actually exclude and bolster and essentially repair from inside a segment of aorta that is dilated, in this particular case we really can't put a stent in there through what we call an endovascular approach. And that's because it's so close to not only the vessels that provide support and blood flow to the heart muscle itself, just above the valve. Those are the coronary arteries you were learning about earlier. But it's also pretty close to where the aorta takes an arch and arches to the left side and sends off blood vessels to the brain and to the upper extremities. And so because of that, in order to remove the threat of rupture of this enlarged area of the aorta, we require an open surgical approach to essentially remove that diseased segment of the aorta and replace it with a synthetic tube made out of, it's a polyester-like material. So right off the bat there, we know that it's not just about the valve. We're going to have to do something about the aorta. That something will require a surgical replacement. And so it immediately starts to make sense that at the same time we should be managing the valve problem surgically as well. There are other aspects to the valve itself that are important. Sometimes a transcatheter aortic valvular replacement strategy in certain types of bicuspid valves works fine. And if you didn't have the aneurysmal aorta, patient might be a candidate for that. But there are other times when it doesn't work as well because the current technology was originally developed to replace 3 leaflet valves that were stenotic, not necessarily all 2 leaflet valves, and that's where we get back to the kind of rigor and imaging interpretation that Dr. Nair is capable of contributing to the team. When we look at the ultrasound closely, when we look at the CT scan, we can at times determine that actually, even if there isn't an aneurysmal segment of the aorta, we need to replace the valve surgically. And that actually sets the patient up. In this case, it's a young patient, sets the patient up for success in the future. Maybe you want to talk about that.
Sure. And this allows me to highlight the technology that Dr. Vial just referred to, which is called transcatheter aortic valve replacement. It's one of the amazing inventions of the past decade. And El Camino has been at the forefront, actually, of this procedure. Dr. Vial, others in this room, Dr. Ramahan, who isn't here today, have been involved in this. And this is an amazing procedure where going from an artery in the leg, the large valve can be threaded through the aorta and replaced from the inside without the need to make an incision in the chest. And that can replace the need in some cases for surgery. Now, in this particular case, because it doesn't address the aorta, it's not our first choice, but let's say this patient gets surgery by Dr. Vial, spends a few days in the hospital, 5 days in the hospital, goes home, and then the replaced valve may fail eventually. These replaced valves don't last forever, so maybe 10 years later, that valve may fail. Historically, the only thing we used to be able to do was a second surgery, which is still an option, but is obviously complicated to have a big surgery twice. And so second, the other way is we can then re-replace the valve using this TAVR procedure the second time around. So the initial valve serves sort of as a scaffold for us to put the second valve in. And that actually is a very well-tolerated procedure. Often people go home within a couple of days of that procedure, and they have a new valve now, which can last them hopefully another 10 years or longer. So that's a very exciting new development. So we not only do we try to fix the problem now, but now with these new technologies, we need to kind of think about the 20-year plan, the 30-year plan. What are we going to do down the road when this technology fails or when a problem comes up?
Yeah, I would say that I think we need to be availing ourselves of the opportunity to create a solution that not only fixes the problem, if you will, that's right in front of us, but sets us up for further interventions in the future should they become necessary, that in many instances can be accomplished minimally invasively if we do the right thing up front.
Quickly, gentlemen.
Yes.
There is another procedure that we do in structural heart. And so I'm just going to give you a little bit of a background of a patient, and perhaps we could talk about the mitral valve now. Mr. Brown is a 75-year-old man with a history of coronary bypass surgery. He recovered completely and resumed his normal activities, thanks in no small part to his cardiac rehab classes. Over the years, he has been followed by his cardiologist, who noted some leaking or regurgitation in his mitral valve. It has now progressed to severe regurgitation, and Mr. Brown has been forced to reduce his activities due to shortness of breath. His cardiologist has referred him to the multidisciplinary valve clinic for evaluation.
So we always start the same place, so getting a good history physical, and this is a plug for imaging. So this is a field, mitral valve disease, and maybe we can show the image of the mitral valve, but when the mitral valve is leaking, we try to get all of the right imaging through echo and other technologies, sometimes CT or MRI can be involved, to get an idea of exactly what the problem is. Is the valve torn? Are the leaflets getting pulled apart? The image on the left, that jet that you see going backwards is backflow through the mitral valve. And this often can occur as people get older because the valve can tear because of just wear and tear on the leaflets, though there are a long list of causes of mitral valve disease. When this happens, this can cause backflow of blood, which causes shortness of breath and can cause other problems like heart failure. And again, historically, the best initial solution used to be, and in some cases still is, surgery to fix the valve, which Dr. Vial will discuss. But we wanted to highlight also the ability to do transcatheter techniques to fix the mitral valve. And I also want to call out Dr. Senghor, wherever he is, who is the inventor of the technology we're going to highlight here, which is called MitraClip. And amazingly, this global technology was invented by our very own Dr. Senghor, and has served hundreds of, correct me if I'm wrong, hundreds of thousands, 200,000 people, Fred says from the back. So he's really changed the world here. And this procedure involves going in with catheters. You see how we have a theme here. Go in with a catheter and cross that hole, like we said, with the electrical procedures, and then go in and place this clip on the valve to capture the torn segment. And there are a lot of details, but to do this well, you really have to be able to see the valve and figure out exactly where the problem is. And that's some of the challenge of planning for this procedure, and it really requires a team-based approach to make that decision. And Conrad?
So I'm in earnest when I say to you that some of the most exciting and fulfilling care delivery interactions that I've had with colleagues and with patients have been about finding reasons not to operate, not to do open heart surgery. In a patient who's already had an open heart intervention for another reason, going back in is certainly doable, and fully a fifth of the cases that I do are those kinds of reoperative situations. But if you can avoid that and avoid the additional risks associated with doing that, and solve the problem for the patient through a minimally invasive approach, not only are you helping that patient, but the availability of that technology opens up the opportunity to help many more patients that might otherwise have been able to be helped if all we had was the open surgical approaches of the past. And this is why Dr. Senghor's invention and the entire team that worked with him to bring this forward, and the very robust research that has been done on this, and that we've participated in all along here, is such a service to patient communities far and wide. This is a real game changer. It has been, just like TAVR.
And just on that point, I think this is a rapidly changing field. And it's one of the reasons it's so exciting is that none of these procedures were things that were really done commonly when I finished training or when I joined here 15 years ago. They were just kind of starting. And now every year, this is a rapidly changing field. We are involved in a trial of fixing the tricuspid valve. There are now procedures to put new valves in all of the other valves that we mentioned, pulmonic, tricuspid, mitral. And so there's the innovation of Silicon Valley has really shown itself, and the world really has shown itself in this field with the explosion of new technologies, which is great, but is complicated because as a patient, it can be hard to navigate what's the best choice. And so if finding a team of people that are willing to talk to each other and discuss you and your best option and weigh your other medical problems is probably really at the heart of getting the best outcome.
Pun intended.
I realized it as I was saying it. Yeah.
So maybe some questions from the audience, both online and in person?
Yeah, and a mitral valve repair.
Oh, hold on, just 1 second. We have the mic's coming.
Here comes a mic.
Yep.
In a mitral valve repair, what is the longevity of that repair typically?
So in the instance of surgically repaired valves, the intent is to confer a lifelong benefit on the patient. The data that we have to really look at that is covering only about 20 years at this point in our surgical experience. And techniques have continued to evolve over that time period, and therefore the numbers and the types of valves that were or are now amenable in the right hands to repair versus replacement has expanded with that increased knowledge and experience. And so it'll be a few years before we really can truly objectively test by following patients whether or not that is in fact the case, that it is a lifelong repair. That said, that's one type of repair. We've just talked about a catheter-based type of repair, and maybe you want to talk a little bit about the outcomes there.
I want to emphasize that not for young patients who have valve problems, often the surgical approaches are still the favored approaches because of the ability and the data that this will last your whole life, hopefully. So the patients for whom we consider technologies like MitraClip are typically considered high risk for surgery for some reason. Like, for example, they've already had surgery. So not everybody should have this technology. But when it works well, which is now most of the time, and this is usually a durable repair, and we can often reduce the leakiness of the valve from severe to mild. Most of the patients in whom we do this procedure are elderly, and that's why they're not considering a surgery right off the bat, and often it serves them for their whole life without trouble. So, but all of these things are very individual, and everyone's valve is different, and so the challenges can be different. And there are cases where these technologies, where no catheter-based technology would work, and a more extensive surgery may be needed in order to fix the problem.
Maybe a question from online?
Sure. So someone would like to know what the different cardiac tests are available to help identify aortic valve disease.
So there are a lot of tests out there, starting with a physical exam. For aortic valve disease, it turns out that listening with a stethoscope is pretty good at getting at least to ruling out severe problems. Because many of them cause a heart murmur, that's pretty obvious. But probably our best go-to technology is ultrasound, is echo. And echo is something I'm excited about, and many of us in the room are really spend a lot of time reading ultrasounds. It's a easy, non-invasive bedside or outpatient type of test where we put an ultrasound probe on the chest, kind of like I often say ultrasound, like people are familiar with ultrasounds for maternal scans or when people are pregnant. Similar idea, just a picture of the heart, and we can see the valves working. We can make measurements using Doppler and other ultrasound techniques, and we can measure the valve and tell with great accuracy exactly how narrowed the valve is. There's a whole another series of more advanced types of tests, CT scans, MRIs, what's called a transesophageal echo, where we put a probe down the throat to take better pictures of the heart that are sometimes needed. And usually just physical exam and echo, though, is the number one way to kind of make a diagnosis.
Yes.
I've had aneurysms put in, clips put in to prevent aneurysms from basically blowing and causing a stroke. You talk about the mitral valve clip, that it lets the blood still go through but not come back up. Can you go into that a little bit more? How does it allow, because I'm trying to put the two together. When you
Yeah.
put a clip on, normally it stops something from happening.
Yeah, so,
how does it work for the heart?
I think I'm understanding your question, so keep me honest here. But for example, in the brain, in the cerebral circulation, there can be aneurysms that are clipped for the purpose of essentially excluding them. So you've got an area where there's a sac-like protrusion from the wall of the tube, if you will, and you put a clip on the outside of the vessel so that essentially blood coursing through the tube no longer has access to that area that became weakened. And in that regard, you are preventing, as you pointed out, a rupture and stroke, et cetera. In the case of the clip on the valve, what we're doing is we're actually working from within the circulation. The clip is actually dwelling within the circulatory path of blood. The mitral valve works because there are two specialized flaps of tissue, we call them leaflets, that essentially function like a two-planed or two-leaflet trap door. And when there's leakage, a clip placed in the middle portion permits, when the valve is open, for blood to access and flow down into the ventricle more or less unobstructed. The opening now is no longer a single channel opening, it's a two-channel opening because there's a clip in the middle. But the clip maintains a level of alignment between the two leaflets such that when the valve is meant to be closing, those leaflets are in a position to interact with one another more normally, if you will, to achieve that closure. So you kind of get the best of both worlds. The valve still opens and the ventricle can fill, the pumping chamber can fill adequately, but when the valve is meant to be closed, the leaflets are better aligned to be able to do that. Does that make sense?
Yeah, I think that top view on the bottom right illustrates Dr. Vial's point, where you're sort of clipping the middle of the valve, but the side's open. And one of the big challenges with this procedure is you're always making the valve a little narrower. And so sometimes we put 1, 2, 3 clips on. We have to always make sure that we're not narrowing the valve, which is another problem altogether.
Any other questions from online?
Yes, if you have a MitraClip and the leaking persists, what would the next steps be?
So we know, and actually the record of accomplishment in this program in the hands of my colleagues technically and of all of us, if you will, from an intellectual decision-making perspective, the results have been excellent in this regard in terms of the amount of residual regurgitation or leakage that patients are experiencing after the placement of a clip. That has everything to do with the imaging interpretation up front and the proper selection of patients on the basis of a known ability or forecasted ability for them to benefit. In some instances, if you look at the worldwide experience with MitraClip, the amount of reduction in the degree of leakage is not as much as one would have intended or the care team intended. And in those instances, it depends very much on the patient in terms of what the next step is. Some patients were receiving the MitraClip because it was known up front that they were really not appropriate candidates for any form of open surgical intervention. Other times, it's more of a relative indication, and we think that the patient could have surgery, but that they had sufficient burden of risk that trying a MitraClip first makes sense. And in those cases, if the MitraClip doesn't achieve the benefit that we were after, or that the care team was after, there may be an opportunity for surgical intervention because you haven't burnt that bridge. That surgical intervention almost always requires surgical replacement of the mitral valve with a mitral valve prosthesis, but we know that in the patient populations in whom this kind of two-step process might occur, we know that they can be benefited from that. But we're always trying to achieve the most benefit for the least risk. And the approach that the team takes is, hey, for this patient, do we think a clip has a decent chance or a good chance of benefiting the patient? And sometimes, if you're not entirely sure, you give the patient the benefit of the doubt, have them try that first, and then if it doesn't work, there may be surgical options on the other side of that if the patient is a fit surgical candidate. Anything more?
No, I agree. I think that's exactly right. And I think there are cases where we could place an additional clip sometimes. So there are times occasionally where another procedure could be done, but Dr. Vial's summary is exactly right. And the nice thing about many of these procedures is that the risk is very low. So the procedural risk for mitral clip, for example, is exceedingly low. It's nearly 0% complication rate. And so because of that issue, it's worth considering for many people. Now, again, that's because of patient selection. If we did it for everyone, it wouldn't work as well. But if you pick the right people, then it does tend to work well.
Yes.
Hi, thanks for the information, and it's amazing that this was invented here, the clip. The question I had was with respect to shortness of breath in the context of the discussion here. What practically or physiologically causes the shortness of breath in this context?
Great question. So the question is, what makes you short of breath with mitral valve disease? And it's actually the direct backflow of blood going backwards through the valve raises the pressure in the upper chamber, and the next place backwards from there is the lung and the lung blood vessels. And it turns out your upper chamber and your lungs have sensors for pressure. And so as the pressure goes up, you will feel short of breath, and there'll be a sensation that you're not getting a deep breath. If it gets more severe, there can actually be fluid buildup in the lungs, and that's a form of heart failure related to the valve disease, which makes people extremely short of breath. But even just the high pressure is sensed by the body, and usually people feel out of breath.
Did you have a question for before?
I was just going to comment that when you were speaking about, you spoke about the aneurysm.
Yes.
And I was thinking that when you were saying about the mitral valve, this and this and this, I was trying to think about my neurological section. If there were like 7 or 5 of them in there, you would put a mitral in each of those instead of doing surgery. And then I concluded 5 years.
So you're wondering whether you could use it in other parts of the body? Yeah, I don't think you'd want it in the brain. That would probably not go well. but no, I mean,
Dr. Sangor had MitraClip on the brain for a lot of years. And you can see what happened there.
Yeah, exactly. He's turned out pretty well, so it might work.
Sure.
Well, to your point, people are coming up with these ideas all the time. Why don't we put it on this valve, or that valve? And it's how the field is progressing. There's a lot of innovators in this area just thinking about different ways to use these technologies.
Okay.
Got the hook.
Thank you all, everyone.
Thank you very
Thank
much.
you.